organizing committee for the kind invitation to talk about the key role CT has in the evaluation of patients considered for TAVI. CT is now the gold standard for the annular and aortic root dimensions. It can identify high-risk anatomy for adverse events such as coronary obstruction and can provide us with the least risky transcutaneous access route. The aortic valve calcium score, although not compulsory, is really useful in low-flow, low-gradient aortic stenosis. It has been shown to provide excellent discrimination for severe aortic stenosis using gender-specific thresholds. How we scan the patient depends on our scanner and the technology it has. Nevertheless, the two main components of the TAVI CT workup are ECG synchronized data for the aortic root and a whole-body CT angiogram. The latter is commonly performed as an ungated scan for peripheral access vessel from skull to upper thigh to include aorta, iliac, femoral, subclavian, and carotid arteries. We need to look really carefully in this vascular CT angiography to assess any high-risk anatomy for vascular complications, such as insufficient vessel diameter, increased calcification and its distribution, increased vessel tortuosity, the presence of aneurysm, dissection, or stents. Once the transfemoral access is contraindicating, then we can look into other access routes like left subclavian, left carotid, transapical, transcaval. Focusing now on the aortic route, the scan should be ECG gating because we know that the aortic annulus is a dynamic structure, highly mobile during the cardiac cycle, changing its shape during the cardiac cycle and reaching its maximum diameter during systole. So the scan should at least cover the systole. And what we do in CT in terms of TAVI sizing is exactly measure this virtual Bayesian ring by identifying the hinge points of each cusp and unite them in a planar way. And we can do that manually, or the software can do that automatically for us. At the end, we have the true plane of the annulus, and then we can do our measurements, including not only the minimum and maximum diameter, but also measurements regarding the area and perimeter, and have the diameter derived by them. CT can provide us with fluoroscopic views regarding the C-arm during the procedure, reducing the procedure time and the contrast given to the patient. Really important is to study the landing zone for calcifications to describe the burden, the location, and any extension, not only in the aortic valve cusps, but also in the annulus and the LVOT. And this landing zone calcification has implication in terms of paravalvular regurgitation, annular rupture, stroke, and pacemaker implantation. The risk for paravalvular regurgitation increases when we have an asymmetric calcified cusps, a large oval-shaped annulus, non-fused commissure adjacent to calcified masses, and LVOT calcifications. In case of calcium in the upper LVOT and below non-coronary cusp, the risk for annular rupture increases. With CT, it is mandatory to measure the coronary ostial height perpendicular to the annular plane, as well the sinus of Valsalva diameter and the height of STJ. Ostial heights less than 12, sinus of Valsalva less than 30, and a narrow and short STJ increases the risk for coronary obstruction. On CT, we can also measure the length of membranous septum, and if it is shorter than 8 millimeters, And if this is accompanied by high left coronary cusp calcium burden, then the risk for post-TAVI conduction abnormalities is increased. In terms of bicuspid aortic valve, we have now a new classification, more TAVI-centered, depending on the number of commissures and the number of raphes. So we have three types: the bicommissural with no raphe, the bicommissural with raphe, and the tricommissural, which is actually the functional bicuspid. And the bicuspid aortic valve has high risks in terms of TAVI. We know that there is the bicuspid aortic valve aortopathy, and the high risk includes also the long raphe, the low coronaries, the coronary ostium near commissure, the dense leaflet calcium, the calcified raphe, and the LVOT calcium in general. Annual sizing, in terms of TAVI sizing, is a little bit more challenging than the tricuspid, because instead of having 3 reference hitch points, we have now 2. However, sometimes we have to keep in mind that in bicuspid there is some underexpansion, and we have to bear in mind that perhaps the annular place is not anymore the smallest part of the aortic root. So it is recommended to go a little bit above 3 or 4 millimeters and do some supraannular measurements. In terms of a virtual raphe ring measurements, and this can be like a perimeter, the intercommissural distance, the adiraphe space, and the raphe length. If the raphe length is more than 50% of the diameter derived from the perimeter, as well if the calcium volume of the raphe is more than 300 square millimeter, then we have a high risk for underexpansion. Lastly, more and more people are in need now for valve-in-valve TAVI and TAVI-in-TAVI. These procedures are more associated with higher risk of coronary obstruction, and CT can be helpful by assessing the virtual to coronary distance and the virtual to STJ distance. Risk factors are leaflets above coronary ostium, a narrow sinus, VTC less than 4 millimeters or 3 millimeters, low and narrow STJ, and VTS virtual to STJ distance less than 2.5 millimeters. In conclusion, CD is now the gold standard for aortic annulus measurements and providing the best vessel access route. It can identify high-risk profile for TAVI in terms of complications. It can be helpful in valve-in-valve TAVI and TAVI-in-TAVI, and all this knowledge should be passed to the interventional cardiologist so he can alter the procedure. Thank you very much.
Thank you very much for a nice presentation. The bicuspid valve is a challenging valve in CT.
Indeed.
Do you measure, you said 4 millimeters above the annulus in some cases. Do you measure 8 millimeters above the annulus and comparing the 4, 8 and the annulus size?
So 4 is not compulsory. You should find the narrowest part of the aortic root. In most of the cases, it can be 3 or 4 millimeters, but you have to go to the narrowest to see well the raphe, because it is more common in this bicommissural with raphe, and do your measurements there.
Thank you. Any comments from the panel, from the online? Okay, so we move on to the next presenter. Dr. Stathogiannis, performing TAVI.